Oh, because you're doing the same thing. Well, because the rebound challenge is just to pull it apart and let it spring back to see if it's a lesion. If you have to do the correction, you're actually resetting those receptors. That's what you're asking. So then it's no longer a rebound, it's a correction. You do it. It's the time. Yeah, how much? Yeah. That's a good question. Got a more direct answer to this. Yeah. Okay, now are we ready? Face that. Yeah, I should have made all that time. So we did upper trap, and what we should have done right after that is rhomboid. So rhomboid, you're going to be standing on the right side of your patient, testing the right rhomboid. You bring them into full elbow flexion, roll their shoulder complex back. The humerus will roll back too, but you want to get their whole complex back. Stabilize the shoulder gently, and so you can feel for scapular movement. Full right elbow. Now, if there's a problem with the shoulder, a lot of times that arm will give way, but you're feeling for scapular motion. The scapula doesn't move. Then you might be testing something out. You're going through a lot of structures. So that's the rhomboid. Now, the rhomboid, thanks for a minute. Have their head turned slightly away from the side you're testing. Now you go from the rhomboid, drop your shoulder down, have them turned slightly away, same test, and this is it. This is to access the odd test for the levator retractor. Yeah, so this is rhomboid. Now, everybody got that? These are tough to test, the rhomboids. I would have just a little. You come over. You're going to test it. So, if you see, guys, watch over here. See, her stabilizing hand is here. Testing hand is here. So see that testing, that's the testing position I want to see. Now you can also do it a lot of other ways, but this will give you the best test for you as the examiner. Head turns away with both of them. Little head turn with the rhomboid, and then when you do the levator, drop this down. So a lot of times you give a little more. You want to really isolate that. Which is kind of like the rhomboid. Serratus anterior, I can't believe I almost forgot that. So we're at about 180, about 130, 140 degrees. And elbow is straight, head is in neutral, head is pretty much in neutral. You put your left hand on their scapula, or your stabilizer on the scapula, hold that, and you push down. And you're looking for scapular motion, just like you were with the rhomboid. Bring it down where it's straight out from the body, middle division. Bring it down about 30 degrees. You're still above the supraspinatus, kind of between supraspinatus and lower division. And there we go. Serratus antigus. It's right up there with the psoas, a bunch of other. It's really super important muscle. And it was the first muscle that Dr. Goodhart wrote about fixing, the other day. So it really has a special place. Anything else I forgot? Shoulder muscles. Oh, lat. Let's do that stand. Latissimus dorsi. Make sure you are, now watch me really quick. For a second. I'm going to test her. My body is, I'm going to come up to her this way. slightly turn. Use this arm, my left arm, on her left arm. Stabilize the shoulder, hold. I'm going to come over here. I walk up to her, slightly turn. Now, right now, there's my. So it's easy to do this. You come in and you're doing this. Or you're doing this. Don't do it that way. Come in this way and just reach down and there's your punch. It's already set up. We haven't done some of the other shoulder muscles yet. Porco, the clavius, that's right there. We haven't done those yet. Not this class. We haven't done shoulder, but we did last year. Terry's minor, major, all those. We'll do all those next time. Let's switch before somebody else remembers a muscle I forgot. Sure. We'll do a switch on. You need to use restroom or water or whatever.
But thank you. Gosh.
If we started with our patients seated, oh, wait till everybody's back. Hopefully we can break for lunch by 12:30 or 12:40.
Oh yeah, we're gonna do it.
For lunch.
Yeah, I think she needs lunch. I'm hearing.
I'm
No,
gonna
we
need
can do
lunch.
it, but I'm kind of crazy.
You mean we're gonna make it?
Yeah.
Anybody have any?
Does
Does anybody have any? Is anybody running off campus to get?
We can get some.
You sure?
We'll figure it out. Yeah.
I might have to. Because we have a couple talkers.
Yeah.
Me too.
Yeah. Not that much.
This time.
Love the screen set.
What? I told you there's this place in Scappoose now, in my town where I practice, this food cart that does that kind of food. And I thought it was, first I thought it was green. And it turns out it's, they're cereal. They're cereal. And it tastes, it's just like, it's the hummus and the lamb and all the yummy stuff. It's amazing. Oh, good. Good. It's will it be open on Sunday? Are we all back? Okay. Are you doing an eye test? Are you? The glasses, yeah, they will, and they'll also test their prescriptions. A lot of times when people get a new prescription, like a longer one, there'll be a period of time where they're in. But a lot of times, it's just like dental work for especially braces. If at all possible, I was like, just come in after they same way if they have dental work, they have TMJ stuff. A lot of times, I'll try to schedule it after the dental procedures. I mean, anything can affect anything, really. Well, we're all here. You're missing a doctor. Okay, we're going to start with seated. Patient is going to go into, we do deltoid. Start with deltoid. Middle deltoid. So holler it out, and then I'm going to watch. Middle deltoid. Right. So if you're doing anterior, okay, if you're doing anterior, you can. Yeah.
I see, I see.
Yeah.
I'm trying to figure out.
So if you're doing the anterior, you're, as a practitioner, you can be middle and post here, but you come over to their side. If you're doing anterior. Kind of around this way. So middle, anterior, posterior deltoid. Perfect. Everybody look good? Yes, ma'am. So, okay, I'll do this side. So here, internal rotation, your vector changes from here to here, following her forearm. I'll stabilize here. And then I'll come around to the side, this way, and I'm stabilizing with this hand. See, my vector is my forearm matches her on her forearm. Does that make sense? Oh, yeah. So, yeah. So your right arm. Okay. Now, head flexed. Turn to the left. Let's do the two-handed version. Just gently rest your elbows on their shoulder, push in my hand. Good. It also keeps the traps from trying to get involved. You always want to be in the middle of everything, the traps. V-baby. Do your SCM. Do it with two hands, you can do it with one hand. The key is the positioning of your head. And another key is where you get a false positive really easy if you push on the wrong spots. Okay, so upper. What do you mean? Scaling? So, scaling. Or let's do this side first. Side. Actually, this way. Let's do two. And then full flexion, full rotation. Oh, no. Upper trapezius, please. Upper trapezius. In the right upper trapezius. Head turns away slightly. Opposite the one you're testing. Reach up and over. Very nice. Now, so I don't forget these, let's do the serratus anticus. Serratus anticus, as it's written in the old anatomy text. So upper, middle, and lower division. Okay. Serratus anticus. Now, so I don't forget it, let's do the right and left rhomboideus. Shoulder is retracted, head turns slightly away from the side you're testing. Make sure you're on the side of your patient. And you're going to use, so if I'm testing Elle's right shoulder or right rhomboid, using my left arm on her tester and my right hand on her. That's going to remind you, the examiner, of it. Now, while you're there, have her press that shoulder. Give her press that shoulder and turn to the left. Say, everybody got that one. These are kind of tricky. We got rhomboid, yeah, you want them to really, like, it's like you're putting your seatbelt on.
That's my question. You guys don't do that?
You can change.
I grab my. Wait, you guys do driving.
You might allow them to. The key is to monitor and see. Test it for everybody, let's have you lay face down. I think that's where we went next last time, right? Patient is face down. And let's start with the sacrospinalis. We're going to be on the, I'm going to be on the left side of my patient. I'm going to be testing her right sacrospinalis. I'm able to push cross body. Raise the patient up, hold. And weakness will show, and then you come to the other side of the body. You're testing the opposite side.
Oh, that was a little stronger.
So I would kind of get back.
And just to make sure that
Okay, now patient is prone. We're going to test the hamstrings first. As a group. Now we can also test the medial and lateral divisions or parts of the muscle, like we do. Okay, so hamstring. Now, while you've got their knee bent, bring their knee into full 90-degree flexion. Bring the knee slightly away from its partner and rotate externally. You're going to test the prone piriformis. Test the piriformis in prone. Now, it's good if you test on you're on the side. On the one hand. Oh, piriformis. Now, we're going to lift the leg off the table. See if they can hold that while you stabilize the opposite torso. If they can hold that without their knee straight resistance, test the glute max. So watch for knee straight. That's where they'll try to come. They're trying to use their hands to compensate for the body. Gluteus maximus. We did. Okay, so let's see. Piriformis, hamstrings. Oh, middle trapezius. Arm comes out, full external rotation. Have the patient look towards the testing arm and push down. Don't need much leverage. You don't need much pressure. You have no leverage. Now, go right into lower side. Arm towards our neck. Okay, so everybody got the middle and lower track. Middle and lower track. And I guarantee if you're testing it right, probably half in the room are weak. That's kind of the norm. Okay, so let's put our patients, let everything on pro. Have a list in front of you. So, glute max, piriformis, hamstrings, middle of the lower trap. Yeah, that's it. Lay it back. Now your patient is supine. Now let's start out by standing at the foot of the table. And we're going to test the gluteus medius first. Bring the right leg out. Slight extension. And bring it back again. If you put it into a little bit of extension, you'll get a more honest test. And maybe a tiny bit of internal rotation. Now the really effective test, of course, is the side leg. That was the gluteus medius was never high. The weak was never high. Now, since we're still at the foot of the table, let's test right adductor. See my vector, my elbow? And make sure you're taking care of your back. We're going to take the right leg, lift it up about 20, 30 degrees, full internal rotation, a little bit of abduction, testing the tensor fasciae. Tensor fasciae. What organ is the tensor fasciae related to? Anyone? Anyone know what organ it's related to? Somebody said large intestine. Large intestine. PFL, large intestine. Hamstrings, large intestine. Quads, small intestine. Abdominals, small intestine. Acres worth? Oh, man. Adductors are going to be the pericardium meridian and the hormone. Okay, so everything in the pelvis is hormone related, except for the TFL, which is kind of in the pelvis. And of course, the psoas and iliacus, which are kidney. But the glute med, glute min, max, piriformis, adductors, tib posterior, gastroc, soleus, all hormone. I guess the lats technically. Okay, so where were we? Sorry. We did adductors, we did glute med, we did TFL. Okay, let's do rectus femoris, which is related to what organ? Rectus femoris. Anyone? What? Rectus femoris, along with its other quad cousins, related to small intestine. So that's why I give this exercise. I know I'm going on track. I want you guys to see this for a second. This is one of the more typical exercises I give my patients. Watch, just for a second, watch. Sorry. Hold that right there. Piece together. It's hard. I'll bring it up a little bit. Now, if it's that hard, I have them do it with a chair or a couch here so they can have something to and that's okay. So what happens is I have them pretend they've got a platter on their shins. I'm going to move the platter around in a half moon shape like that, and then back. Stabilizing yourself. This is a great abdominal strengthening exercise, and making the quads work with making the quads work with the abdominals. Gets them all popular. So you've got more coordinated movement. Quads, especially the rectus and abdominals, are very biomechanical and neurological. That's a killer exercise. If you can get them to do it, it's kind of hard. Everybody needs abdominal strength, and nobody likes crunches with a beat. So this is kind of another way to do it. Plus, this will get stuff that crunch won't. I also have an exercise over an exercise ball. We go into extension to really access the. Okay, sorry. Now, we did rectus femoris. But always think, small intestine in the front here, all the way from the knees clear up to the diaphragm, the small intestine. Always think hormonal. And of course, with the hamstrings, think hold it. Okay, hold there. So quad is a group. And you can break these down like we do the hamstrings. You come out at an angle, hold. You change your vector, you really don't change the position of the intestine. So rectus and quads. Now, while we're down at the lower extremities, everybody psoas. Alicia, make sure everybody's tested psoas. So, if the psoas test pretty good, then bring it to midline. Test the actual. So everybody got psoas and iliacus. Baker? Get it?
Can you do iliacus?
Iliacus, everyone. Full external rotation. If it's not externally rotated, it's another kind of rectus femoris test. If they have trouble externally rotating that muscle, that might be your test on that. See if they can, wherever they can externally rotate to, have them hold that. And if they can hold it and they're not having pain, and then you can maybe gently test it. But a lot of times, if they have trouble getting into external rotation, that's telling you that the muscles are working. So iliacus, psoas, quads we did. Okay, so supine piriformis. Hip at 90, knee at 90, full external rotation, stabilize, and was ideally be on the side that you're testing. Performance would be pretty strong on some folks. Now, we're moving up to the upper body. Pectoralis major clavicular. Full external rotation. 90 degrees flexion. And basically neutral adduction. Stabilize the opposite shoulder and test. And then move your stabilizing hand down to the opposite hip and vector between those 2 points. You'll get the lower back. Oh no, yeah.
Yeah, just put your head. Yep.
And then when I go to sternal, do I switch hands and?
Perfect. Yep. Gorgeous. Yeah. I had to try it on for 5. Yeah. No, it's just.
So pec major, clavicular, and sternum. Okay, pectoralis minor. Make sure the shoulder is translated. Now, what's the pec minor? What did we talk about with the pec minor related to another system last session? Retrograde lymphatic. Tested people at a slant, and then we, so pectoralis minor is something to consider. If it's weak or hypertonic, it can mess with your lymph drainage, that final lymph drainage. That was last session. Pec minor is also, what's that? Retrograde lymphatic technique, which is here. Now remember this, the pec minor doesn't attach to the humerus, it attaches to the scapula. So when it contracts, it moves this, but it doesn't move this. This is pec major clavicular and sternal. So a lot of times when somebody said, I just had it this last week, the guy, can't bench press. I don't know, can't bench press. Something's wrong, I can't bench press. And he injured his pec minor. So he was basically getting a reactive muscle situation where when he went here, instead of the pec minor bringing those shoulders this way, he wasn't doing it. So he couldn't do push-ups either. So he got his pec minor going, and now he's slowly kind of getting injured at doing bench press. So this is a really important muscle to learn. A lot of times it gets missed. Because you can't see it. You see the pec major. People spend a lot of time to get the pec majors visible. Okay, pec minor. What's left here? QL. Thank you. QL. You're going to stand on the side opposite QL you're testing. And you pull the legs forward. And then you go around the other side. This is where a tall table is. And now remember the chapter reflex for heck minor is right here, which is also where the chapter is for the diagram. So palpate along there, you look for problems, you can TL that area, and that might lead you. Oh, the sweet, yeah, that's the conception test. Yeah. Okay, so what's left? What did I miss? Sit on the end. Abdominals? Oh, yeah. Sorry. I missed a whole bunch. Good Lord, I must really be hungry. Okay, so everybody, sartorius. If you're not sure, look up here where I'm doing it. Even if you are sure, double check. Hold there. Okay, that's the motion you're doing. You're using both testing arms. Make sure that the heel of the testing leg is below the knee. Otherwise, you'll get too much hamstring. Too much hamstring recruitment. Now, the gracilis, you move the legs over like you're testing the QL kind of. And you make sure that the testing leg is internally rotated. You bring your vector in line with, you're at kind of at 90 to their tibia. Now, sometimes you'll have to go a little further. You might be picking up the other adductor. And what is the gracilis and sartorius both related to? Breathing. And the pericardial version. Foot muscles. Foot and ankle. So the first thing we're going to do is we're going to pick up the leg. We can do a quick supine hamstring test while we're there, and then have the patient fully plantar flex, and then grab a hold of their calcaneus and pull. See if it goes weak. So you can tell if you get a strong hamstring test, and then you go there, then you know you've got a weak test. So if both are weak, then you might have to do some chasing down. So gastrocnemitis. Don't let it be your nemesis. Get at that. Sartorius gracilis. Now, erroneous longus and brevis. Erroneous longus and brevis. Foot is in full plantar flexion, eversion. Your vector is going to be as much as possible like 90 degrees to the lateral edge of the foot. But once again, a high table is just
Yeah, you gotta get comfortable getting low in this.
I'm a little
First, it's a little, yeah. For, what did you just do? Longest and brevis. So, longest and brevis is plantar flexion and eversion, and then you're stabilizing.
now you're going to move the leg off of your table to do this tib posterior.
And then if you let me
The opposite leg out of the way. Tib posterior, just like erroneous longus and brevis. Tibialis posterior, related to, once again, the series check. What's the tib posterior related to? Three? Like the gastro. Okay, so we got to look right. Okay, bring the foot into dorsiflexion. We haven't already. Toes slowly flex, tib anterior. So what's the organ initially? Tib anterior. Water element. Thank you. Bladder. No, they said water. Yeah, water element. Bladder. So bladder is going to be tib anterior, peroneus, and the flexor digitorum, or flexor hallucis brevis. We get all four directions. Peroneus, tertius. So, do you leave the toes in neutral with the peroneus tertius test, or do you flex them or extend them? Curl them down. Why do you do that? Yeah, you have to keep the extensor digitorum moved from kicking. Same with the extensors. I don't worry so much about the extensors, though they. I mean, if you put your foot into tib anterior testing position, the extensor digitorum group really help tib anterior. So I think that's what it is. Now, big toe, the great toe. Great toe. First, you come in, foot at the table. My right hand to her right foot. Pick up the foot, stabilize the first leg. The proximal phalanx in flexion. Hold, right, don't let me take that. Now, while you're there, bring the great toe into extension. Grab a hold of it and see if you can bring it into flexion. Now, go back to flexion. You're going to stabilize the proximal phalanx. And you're going to try to extend the distal segments. That's flexor hallucis. Well, that's good. Okay. First one's brevis, second one's long. Now you can do the longest if you hold the foot again and stabilize the proximal segment. Bring the end segment, the distal segment into extension, and try to take that out. That's going to be extensor hallucis. I think that's everybody. Is that everybody? Oh, yeah. Yeah. Flexor digitorum group. And then, of course, the extensors. These are really good to monitor when you're treating got nerve root issues with patients with disc problems. These muscles will be very sensitive. They'll be sensitive to subtle changes. You can test them pre and post adjustment. You can with reflexes too, pre and post. Watch and you'll see. Okay. You guys are in pretty good shape with your testing, from what I can see. Now, whatever corrections we might have made today in your hand placement, try next time you're practicing, try to remember that. So, break for lunch. It's almost 1. Come back at 2.
You are the glue to this. I'll let you know how it is, though. Okay. Anyways, let's make a burrito. Do you want that?
Sure, well, yeah, whatever it is. Yeah, that's easy, I would love it. Yeah, if not, whatever, if somebody's going somewhere, let's grab me something. Yeah, I'll give you some.